Okay, hello everyone and welcome to today's webinar. The webinar is on the role of type-specific and confirmatory Herpes Simplex Virus IgG testing in diagnosing genital herpes. I'm Amber Morcom from DiaSorin and I'll be the moderator for today's event. Today's educational webinar is presented by LabRoots and brought to you by DiaSorin. To learn more, visit diasorin.com. Today, we encourage you to participate by submitting any questions you may have during the presentation. To do so, you're simply type them into the Ask Questions box and click Submit. We're going to answer as many questions as we have time for at the end of the presentation. You may also use the Ask a Question box to let us know if you're having any trouble seeing or hearing the presentation. So now I'd like to welcome our speaker for today's webinar. It is my pleasure to welcome Dr. Harry Prince, who's a freelance medical laboratory immunology consultant who has over 25 years of experience in developing and interpreting HSV antibody tests through roles at Focus Diagnostics and Quest Diagnostics. So without further ado, Dr. Prince, you may now begin your presentation.
Thank you very much. Good morning, good afternoon, good evening, wherever you are. As was just mentioned, I retired 2.5 years ago after 25 years in serology at Focus and Quest. And so some of the data that I'll be presenting today were generated as part of that work. With that, we'll get started. This next slide is my financial disclosure. And here's a summary of the topics we're going to be discussing: HSV types, the anatomical sites and mechanisms of infection and reactivation, factors in transmitting genital HSV infections, methods to identify HSV infections, type-specific HSV IgG testing, and then finally confirmatory testing of those samples that are positive in HSV-2 IgG screening assays. The learning objectives then related to that are listed here. Once I finish the presentation, you should be able to list the 2 main factors responsible for transmission of genital herpes, name 3 reasons why it's important to measure type-specific HSV IgG antibodies, explain why confirmation of HSV-2 IgG screen-positive samples is needed, and lastly, describe the 2 most common confirmatory assays that are currently available. Summary: there are 2 types of herpes simplex virus. They are cleverly called HSV-1 and HSV-2, and the infecting type varies by anatomical site. Genital herpes, somewhere between 70 and 90% is caused by HSV-2, but up to 30% is caused by HSV-1, and there are some increasing trends we'll talk about in another couple of slides. The cold sore on your lip facial is almost always type 1, but occasionally it is caused by type 2. Ocular herpes and herpes encephalitis are exclusively type 1, whereas epidermal forms can be either type 1 or type 2. There are lots of HSV antigens, as you can imagine, for any virus. There's many type common antigens. These are the things like glycoproteins C, E, and H, but then there are the type-specific antigens, GG1 for HSV1 and GG2 for HSV2. Greater than 80% of people are infected with HSV1 by age 40. When it comes to genital HSV, though, that rate is 1 in 5 adults in the US. That's greater than 60 million Americans have genital HSV. There are approximately 1 million new cases of genital HSV-2 every year in the US, and these infections may be asymptomatic or subclinical. This is a busy slide showing the pathway for HSV infection. Basically, the virus enters the body through skin or mucous membranes. There it homes to the nerve tract and settles in nerves near the spine. And then it can be reactivated where the virus travels along the nerve back to the skin where it forms a new blister. What are those reactivation stimuli? This is some of the ones that are most common: physical or emotional stress, fever, exposure to sunlight, tissue damage, and immunosuppression. One of the major impacts of genital herpes infections is neonatal herpes infections. This occurs in about 1 in 3,000 births, as has been studied in the US Northwest and the Seattle area. This can cause permanent neurological damage to the baby despite appropriate antiviral therapy. The highest risk of transmission is associated with new maternal infection late in the gestation phase. And it's often transmitted during the delivery process. The most severe cases are caused by type 2 herpes, but type 1 can also cause neonatal herpes. Let's talk more about genital herpes now. The primary infection, the classical presentation, is characterized by those characteristic vesicular lesions, tender inguinal nodes, headache, photophobia, and neck stiffness. Now, one of the things I want to point out as a major take-home message is that there is no clinical distinction between a primary genital herpes episode caused by type 1 HSV versus type 2 HSV. You cannot tell by just looking at the lesions. Another busy slide showing the typical course of a primary infection. The main thing I want to point out here is that the best days for culture performance are the 8 to 10 day range when the ulcer is in the wet form. And another thing to point out from this slide is that during this whole process, you can have virus being shed from the lesion, no matter if it's in the pustule form or the dry crust form. In contrast to primary, recurrent genital herpes has a different clinical presentation. The symptoms are typically less severe than in primary infection. There's typically fewer lesions present, and the time for viral shedding can be much shorter, 2 to 5 days versus up to 12 days in primary infection. One thing I want to mention is that, again, as I mentioned in an earlier slide, most cases of genital herpes are associated with HSV-2, but there seems to be an increasing rate of genital herpes caused by HSV-1, particularly among young adults. This is a rather old study now from the University of Wisconsin that documented increasing rates of HSV-1 genital herpes among their student population. In 1993, it was 35% of cases in women were due to HSV-1. By 2001, that had jumped to 80%, and a similar change in young men from 20% in 1993 up to 65% in 2001. Now, the precise reasons for this increase aren't clear, but the authors speculated that it may be related to a reduced rate of HSV-1 seroconversion during adolescence and an increased rate of orogenital sex among young adults. I honestly haven't seen any further work on this to really pin down exactly what's going on here. Now let's focus more on HSV-2 genital infections. One of the major factors in transmission of genital HSV-2 is unrecognized infection. 20% of HSV-2 infected individuals are truly asymptomatic. They have absolutely no symptoms. And another 60% of patients have symptoms that neither they nor their physician recognize as an HSV infection. 75% of source partners discover their own infection when their newly infected partner is diagnosed. And 75% of mothers with an HSV-infected newborn do not know that they are infected with HSV-2. So this is a big factor in transmission. And so what are those atypical symptoms that those 60% of people have? These are some of the more common ones. Fissures, either vulvular, penile, or perianal. reddening on the buttocks and thighs, back pain, painful urination, and arthralgia. The other major factor in transmission of genital HSV is asymptomatic viral shedding. Just like the words indicate, this reflects virus reactivation and shedding in the absence of any lesions or symptoms. And in a clinical study where samples were collected every day from infected patients, HSV was detected on 12% of days when there were no lesions present. The higher the clinical recurrence rate, the higher the rate of asymptomatic shedding. And in couples who are discordant for HSV-2 infection, 72% of subsequent transmission events occurred when the source partner was asymptomatic. And so for these reasons, this is considered the main cause of sexual transmission, factor in transmission of HSV. Type 1 HSV and type 2 HSV genital infections have different rates of recurrence, and this has some major implications for counseling and treatment. 55% of patients with HSV-1 genital herpes experience at least one recurrence annually. Compare that to 95% of people with HSV-2 genital herpes having at least one annual recurrence. Patients with HSV-1 are not likely to shed virus in the absence of symptoms, whereas those patients with HSV-2 are very likely to shed virus in the absence of symptoms. So based on this information, patients with HSV-1 genital herpes are best treated with episodic antiviral therapy as outbreaks occur. In contrast, patients with HSV-2 genital infection are best treated by continuous suppressive antiviral therapy. So how do we identify HSV? The old gold standard is culture. This requires live cells from a lesion, and thus it isn't useful for identifying asymptomatic patients. Culture can differentiate between type 1 and type 2, but it may be falsely negative, particularly in recurrent infections, because these lesions shed virus for only a few days. Antigen detection is another option. It also requires a lesion, but the sensitivity of this test is extremely variable, from 35 to 100%. And lastly, there's PCR. This is extremely a sensitive test. It's up to 10 times more sensitive than culture. It can differentiate between type 1 and type 2, and it is indeed the test of choice for cerebrospinal fluid, but serum is rarely, if ever, positive. And that brings us to antibody testing to identify HSV infection. The advantages are that you don't need to have a lesion, because once infected, the IgG antibodies persist for life. Type-specific IgG assays are available, and we'll talk a lot more about that. And it's a little bit less expensive than culture or PCR. But there are disadvantages to serology. You cannot discern the site of infection in a patient that's positive for HSV IgG. You cannot automatically assume that a genital lesion found in an IgG positive person is due to HSV. It could be something else. And the other issue is that there's a time lag between infection and antibody production. This is up to 6 weeks for antibodies recognizing the type common antigens, and up to 3 months for antibodies recognizing the type specific antigens. Let's talk about the prevalence of HSV-2 IgG. Is found in just under 10% of US teenagers and college students, up to 35% of the US middle class, about half of women seeking medical attention at an STD clinic, up to 90% of female commercial sex workers, and up to 80% of men who have sex with men. And not surprising, the seroprevalence rate for HSV-2 IgG is linked to the number of sex partners. If there's more than 50 lifetime sex partners, your chances of being infected are at least 50%. So just to summarize, why do we want to measure type-specific IgG? Well, as we mentioned in that slide before, looking at the different treatment protocols, The HSV-2 infected patients can expect more recurrences than an HSV-1 infected patient, so is more likely to benefit from suppression therapy. Another reason is to identify uninfected persons at risk of acquiring HSV during pregnancy. For this group, you want to determine the partner's serostatus and treat the infected partner in the last trimester and provide counseling. It may be best that this couple abstain from unprotected vaginal intercourse and orogenital contact during the third trimester. Sort of related to this is that to identify pregnant persons that are already infected with HSV-2, you can reassure them that the transmission rate to the baby is low. They should consider suppressive therapy close to term, examine this patient closely for lesions during labor, and if possible, avoid using forceps to extract the baby. So let's move on to type-specific HSV testing. Way back in the 20th century, the only available antibody differentiation method was the University of Washington Western blot. As I hope you can tell from just looking at this picture, this is an extremely complicated, work-intensive procedure assay. It's quite expensive. It is not offered by any commercial lab. It's only offered at the University of Washington. But this is now considered one of the options for confirmatory testing, and we'll talk more about that in a couple of minutes. Now we come to type-specific enzyme immunoassays. These became available in the early 2000s, and what they do is they measure IgG to those type-specific antigens that I mentioned. GG1 is an antibody to GG1 indicates HSV-1 infection, and IgG to the GG2 antigen indicates HSV-2 infection. In my experience of over 20 years, it's been with the Herpes Select type-specific EIA. In this test, the serum samples are tested at a 1:101 dilution. Results are expressed as an index where anything greater than or equal to 1.1 is considered positive. And in the labs that I've worked in, the positivity rate is about 60% for HSV-1 IgG and 23% for HSV-2 IgG. But there is an issue with HSV-2 IgG EIAs, and that is false positive reactivity. Studies of Western blot results for samples that had been tested in the HSV-2 IgG EIAs identified EIA false positive samples. In other words, these are samples that were positive by the EIA for HSV-2 IgG, but negative on the Western blot. Now, most of these samples, up to 90%, had EIA index values between 1.1 and 3.5. And based on this information, in 2015, the CDC recommended that HSV-2 IgG EIA screen positive samples with indexes less than 3.5 be tested in some sort of confirmatory assay. In 2018, based on a later study, this recommendation was revised to samples with an index of less than 3.0, and false positive reactivity was indeed one of the factors that the U.S. Preventive Services Task Force considered in their recommendations on asymptomatic HSV IgG screening. You can see more about that in reference 5. Now, another confirmatory test that was available for a while is the HSV-2 IgG BioKit. This was a rapid dot blot test that you just read visually. A 2005 study found that 93% of samples that were HSV-2 EIA positive and BioKit positive were also Western blot positive. So it looked like a pretty good test. However, 30% of samples that were EIA positive but BioKit negative were Western blot positive. So BioKit was missing those samples, so that's a sensitivity issue. And per the instructions for use, the assay specificity was only 83%. And I think based on all of this information, the product was withdrawn from the market in 2023, mainly due to these specificity issues. And another confirmatory assay that I'm going to talk a lot about is the HSV IgG, HSV-2 IgG inhibition assay. This was developed by Dr. Wayne Biography at Focus in 2002. It assesses the differential inhibitory effects of an HSV-1 infected cell lysate and an HSV-2 infected cell lysate on IgG binding in the herpes select HSV-2 IgG EIA. The reason for including the HSV-1 infected lysate is that it controls for nonspecific inhibition by HSV type common antigens and any cell line components. There's 97% agreement between inhibition assay results and Western blot results, and the few discordant samples that are positive by inhibition but negative by Western blot likely represent earlier detection of seroconversion by the EIA compared to the blot. The median interval from the onset of symptoms to seroconversion is 25 days for EIA versus 47 days for Western blot. And once this test was developed and was validated for the Focus reference lab, it was offered on all EIA HSV-2 IgG positive samples. Again, this was well before the 2015 CDC recommendations. And so here's a diagram of how we do the assay. This is the 1:51 dilution of the serum is added to 3 tubes, followed by the addition of an equal volume of diluent, HSV-1 lysate, or HSV-2 lysate. And after incubation, all 3 samples are tested in the herpes select HSV-2 IgG ELISA. Something to remember for later is that the diluent-only tube is indeed a repeat of the HSV-2 IgG screen on the EIA. And this result, when you're looking at inhibition assay results, must be positive for further calculations to be performed. And here are those calculations. I'm not actually going to go through the calculations, but the interpretations are listed here. An inhibition positive result, which indicates the true positive screen, is indicated by HSV-1 inhibition less than 60%, but HSV-2 lysate inhibition greater than 60%. An inhibition negative result, which means the false positive EIA screen, is indicated by an inhibition value less than 60% for both the type 1 lysate and the type 2 lysate. And a few samples we have to interpret as indeterminate because the inhibition by HSV-1 lysate is greater than 60%. And in those situations, we don't even do any further calculations. And here's just a couple of quick examples. This is an example of an inhibition positive. The unabsorbed index is 2.37, the HSV-1 2.21, the HSV-2 0.16, giving us a type 1 inhibition of 7%, well less than 60, and an HSV-2 inhibition of 93%. This shows a negative where all of the tubes have index values between 1.51 and 1.89. When we calculate the inhibition percentages, it's 16% for type 1 and only 5% for type 2. And for indeterminate sample, if the unabsorbed is 1.89 and the type 1 absorbed is 0.43, that's 77% inhibition by type 1. We don't even go any further. So once we started offering this test in 2002 or 2003, in 2006, we took a look at the false positive rate in our group, and this is some unpublished data from 2006. The bottom line, literally, look at the bottom line, of 2,285 samples, 3% of them were false positive. And as was seen by the Western blot investigators, the 90% of samples that were false positive fell within the subgroup of samples that had EIA screen indexes between 1.1 and 3.5. So remember these numbers for future slides. 3% false positive and 90% of the false positive having low index values. We repeated this study recently in 2023 with a much larger study group and just over 21,000 samples. And in that group, the false positive rate was 1.3%. So that's comparable to the 3% that we saw way back in 2006. And we didn't calculate the indeterminate rate earlier. Here we found that rate was 0.2%. And in 2018, we also did a study to look at the index values of false positive and indeterminate samples. Of 124 consecutive false positive samples, 80% of them had index values between 1.1 and 3.5, so very comparable to what we saw back in 2006 of 90%. But the flip side of that is that 20% of false positive samples had index values greater than 3.5. So if there was no confirmatory testing, we wouldn't know that these were false positive samples. Regarding 63 consecutive indeterminate samples, just over 50% of them had index values greater than 3.5. So our conclusion for this publication was that the CDC recommendation to perform confirmatory testing only on HSV-2 EIA positive samples with indexes of 1.1 to 3.5 was inadequate for identifying false positive and indeterminate reactivity in our patient population. After EIAs were developed, it wasn't long before chemiluminescent immunoassays came along, and these have a much broader dynamic range than EIAs. In 2017, our lab switched from EIA to CIA for type-specific HSV-1 and HSV-2 IgG screening. And again, at that point in time, the option was available to have CIA HSV-2 IgG positive samples confirmed using our EIA-based inhibition assay. One of the first things we wanted to look at was that issue of what the broader dynamic range may have, what effect it may have on index values. So we took these samples that were EIA screen positive but inhibition negative, those same 124, and whereas before 20% had an index greater than 3.5 using the EIA, nearly double, 39% had index values greater than 3.5 using the CIA assay. Interesting, in the samples that were screen positive but inhibition indeterminate, the value was about the same, 51%. It was exactly the same. So due to the broader dynamic range of the HSV-2 IgG CIA screening assay, a sizable proportion of samples with a non-positive inhibition result will be missed if only samples with screen indexes of 1.1 to 3.5 are forwarded for confirmatory testing. So after we switched to CIA for HSV IgG screening, a review of the inhibition results identified samples that were HSV-2 IgG screen positive by CIA, but HSV-2 IgG screen negative by EIA. In other words, the dilution-only tube of the EIA-based inhibition assay was negative with an index of less than 1.1. Well, we then decided we need to look at this a little more carefully. So we did a study where we looked at the EIA screen results for 2,305 consecutive samples that were positive in the HSV-2 IgG CIA screen. And again, let me direct you to the bottom line. Of these 2,305 consecutive positive samples, 1,894 samples were also positive on the HSV-2 IgG EIA screen, and all but 7 of these, 1,883, confirmed as positive in the inhibition assay. In contrast to that, of the 2,305 positives, 411 were negative on the HSV-2 IgG EIA screen. That's 17.8% of samples. And similar to what is seen with false positive, these discordant samples were mainly found in the subgroup of samples that had a CAA screening index between 1.1 and 3.0. Well, then that raised the question, what is the real result, the true result on these discordant samples that are CAA, HSV-2 IgG screen positive, but screen negative on the EIA? To do that, we set up a study to address this. We collected 60 consecutive discordant samples, that's the CAA screen positive, EIA screen negative samples, and 60 consecutive concordant positive samples. On those samples, we then performed the HSV-2 IgG BioKit assay, and then we also performed a laboratory-developed HSV-2 IgG inhibition assay on the CAA instrument. Now, this assay is a research tool only. It is not offered for clinical testing. Like the EIA inhibition assay, though, it employs 3 tubes per sample, but instead of using lysates, we used recombinant HSV-1 and HSV-2. And validation studies showed that there was 93% agreement with the EIA inhibition assay. To interpret the results, we came up with a final result based on a composite reference using 3 parameters: the HSV-2 IgG EIA screen result, the BioKit result, and the CAA inhibition result. For the discordant group, a negative result in 2 of the 3 assays or all 3 tests was interpreted as an HSV-2 IgG negative result, but for the concordant group, a positive result in 2 of 3 of the assays, or 3 to 3 assays, were interpreted as HSV-2 IgG positive. And here are the results that we got. In the discordant group, of the 60 samples, we found that 42 were negative in all 3 assays. Another 14 samples were negative in 2 of the 3 assays, EIA and CAA inhibition, but positive by BioKit. However, 14 of these samples had a barely visible dot on the BioKit, which suggested to us that these were probably false positives on the BioKit. Another 3 samples were negative by EIA and BioKit, but barely positive on the CAA inhibition assay. In other words, the percent inhibition by HSV-2 was just over the threshold for the interpretation of positive. And then there was 1 sample that was positive by both the inhibition assay and the BioKit assay, even though it was negative in the EIA screening assay. But also this sample had a barely visible dot on the BioKit, suggesting that maybe that was a false positive as well. So maybe this number should have actually been 59 of 60, 100%, but we'd already set up the criteria, so we followed them and came up with 98% of the discordant samples were classified as HSV-2 IgG negative. In the concordant group, 58 samples were positive in all 3 assays, and 2 samples, even though they were positive by EIA, were negative by BioKit and by CAA inhibition. So if we use these numbers to get some handle on screen performance, we did some back calculations, and this is what we got. Of the 2,305 positive samples that we used in the study, assuming that that represents 23% positivity rate, that means that the starting group was probably around 10,000 samples. And that means that 7,717 were considered negative. Now, we don't have a way to tell how many of those may have been falsely negative, but per the instructions for use for various CIAs, that number appears to be extremely low. So for the purposes of this exercise, we're going to consider that these were all true negative. So of the 2,305 positives, we already know from actual data that 1,894 were HSV-2 IgG EIA screen positive, 1,883 were positive by inhibition, and 11 were negative by EIA inhibition. So that brings us to this group that 411 samples that were HSV-2 IgG EIA screen negative, even though the CIA result was screen positive. And if we apply the percentages from the study of the subgroup of samples of 60 discordant samples, that we get numbers that 404 would be considered negative by a composite result, and 7 would be considered positive. So this combined number of 415 screen positive but final negative results is a bit alarming, but when we plug these numbers into assay performance calculations, we see a somewhat different picture. When we do that, again, we find that the sensitivity is 100%, but more importantly, the specificity is 95% with an efficiency of 96%. This information is very consistent with data provided in instructions for use. So even though it did seem alarming overall, when you look at the entire population being tested, the specificity is within acceptable ranges based on what manufacturers purport from their studies. Now, after this, a recent study was published that assessed the performance of multiple CIAs using samples that had previously been tested by Western blot. They found that for HSV-1, the sensitivity ranged from 86 to 95%. The specificity ranged from 90 to 99%. For HSV-2 IgG, sensitivities range from 85% to 96%, and specificity 95 to nearly 100%. Now, the CIA false positive rate for HSV-1 IgG was higher among samples that were Western blot positive for HSV-2 only, and vice versa. This suggests that some false positive results are due to GG1, IgG2 cross-reactivity. And in all CIAs that were evaluated, samples with positive indexes between 1.1 and 3.0 had the highest percentage of false positives, both for HSV-1 IgG, which is new information, as well as HSV-2 IgG. So the conclusion of these investigators was that there remains room for improvement of HSV IgG CIA testing. So what is the future of HSV IgG testing? Well, one thing is we need to define and establish a gold standard for HSV IgG detection. In my opinion, Western blot is inappropriate for that purpose due to its limited availability and the delayed seroconversion timeline for HSV-2 IgG. Secondly, we need to identify ways to fine-tune the structure of recombinant GG1 and GG2 to improve assay sensitivity and specificity. And as previously suggested by the group that looked at multiple CIAs, we need to encourage both EIA and CIA manufacturers to develop a confirmatory option for their assays. That is, include absorption reagents and instructions for their use, enabling on-site performance of confirmatory testing. And based on the new information that came from that recent study about HSV-1 IgG, we need to design studies to assess, determine if there is really a need for confirmatory testing of HSV-1 IgG positive samples from patients with suspected genital herpes. And lastly, we need to encourage review and perhaps revision of CDC recommendations for which HSV-2 IgG positive samples require confirmatory testing, because many false positive samples are missed using a cut point index of 3.0, particularly for CIAs, and this leads to misdiagnosis and inappropriate patient care. With that, here the next one, in the next slide, I've listed the 12 references that I used for putting the presentation together. And with that, I thank you for attention, and I'm happy to answer any questions that you have.
Thank you so much, Dr. Prince, for such an informative presentation. I know I personally learned a lot. So now, like Dr. Prince said, we're going to start with live Q&A portion of the webinar. So again, if you have a question you'd like to ask, please do so now. As a reminder, just type your question in the Ask a Question box and click Submit, and we'll go ahead and answer as many of your questions as we have time for. So let's get started here. Dr. Prince, the first question I have for you is, do you anticipate stronger guideline changes to be implemented as we move forward, given the difficulties in current testing and, like you mentioned, some of the recent study that was done?
I certainly hope so, that there will be some revisions to guidelines about which tests need to be forwarded to confirmatory testing. Even though the number of false positive samples is small, particularly the number of false positives that have index values greater than the current CDC cut point of 3.0 is small, each sample is connected to a patient. And if you don't do confirmatory testing on a patient that has an index of 4.5, you're giving the patient incorrect information that they're infected with HSV-2 when they really aren't. So we need to address this somehow, in my opinion. Okay. One of the questions here, is there any clinical utility to HSV IgM? The answer is no, because it's nice and sensitive, but the problem is that 30% of individuals that are having a recurrence are positive for HSV IgM. And even worse than that, a small percentage of samples are positive for HSV IgM to one type when they're having a recurrence of another type. So it is a totally unreliable marker of recurrent HSV. A totally unreliable marker of primary infection and should not be used as such. So,
thank you so much. Do you think there's anything a laboratory could do today to improve the HSV result quality coming out of their lab? Maybe something that you changed when you were working at Quest, for example, or
the main thing is, understanding what assay you're using and what the dynamic range is. And if you can get a handle on what percentage of samples have high index values versus low index values, and really try to, if you can do it, develop your own inhibition assay or send it out to somebody. But, the need for confirmatory testing is very real, I think, and that should be considered when you're developing an algorithm.
Speaking of algorithms, is there any considerations that need to be made with the testing algorithm when looking into the population that is being served at the laboratory you're working at? For example, if you're at an at-risk population laboratory.
Sure, yeah. Well, and having experience working in a reference lab when it's not really a targeted at-risk population per se, it's different than if you're working like in an SD clinic or a women's health clinic. You need to really understand the proportion of samples that are false positive in your population and how you want to handle those. So.
Okay. Herpes is specific to males. What makes it specific in males?
I don't quite understand the question. It is not specific to males. Both men and women have genital herpes infections. Um, uh, so it's found in both women and men, and particularly in pregnant women, it's important to know if they're infected or not to decide how to handle the birth when it happens, or to prevent an uninfected pregnant woman from becoming infected during pregnancy.
Thank you. In your opinion, do you think HSV testing will ever get to a point of being included as part of general STI screening?
Someday, if we can find a way to resolve the false positive question, then it may move into general STI screening, but it certainly is not ready for prime time at this point in our history.
Okay. In your experience, what is, maybe like the top 3 things that you think are most important about HSV testing, maybe that you learned along your way or in your career?
Good question. Well, first of all, learning that genital herpes can be caused by both HSV type 1 and type 2. And I've always been concerned about whether HSV-1 genital herpes requires the attention from a laboratory standpoint that HSV-2 IgG testing has gotten. In other words, do we need to be doing confirmatory testing for HSV-1 in individuals, particularly those with suspected or with genital HSV herpes. The other is, the work with false positive, and I have to admire Wayne Biography for how he developed the assay. It was not easy, so I learned a lot from him as far as how you develop an assay. And third is just the varied technologies, EIA versus CIA versus even more modern methods for doing IgG detection, how differences in methodology can affect laboratory result interpretation. Are you there, Amber?
Oh, sorry about that. I was on mute. Is there anything that you could think of that you would like to expand on or recap for the audience, just that's most important that was in your presentation?
Not really. I mean, I think, the points that I wanted to make are why type-specific IgG testing is important, given that it is important, knowing that there are caveats to HSV IgG testing. We're moving to try to resolve those issues. There's several people working around the world to try to resolve those issues, and hopefully once those issues are resolved, hopefully there won't be need for confirmatory testing anymore, but at this point in time, we do need confirmatory testing, and that information needs to be distributed to physicians seeing people with suspected genital herpes, that they should not just rely on the screen result, particularly if the screen result is positive but with a low index.
Thank you so much, Dr. Prince, for your time today and your valuable presentation. We also want to thank LabRoots and our sponsor, Diasorin, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for the questions that were submitted. Questions that you still have can be submitted during the on-demand period, and we can still address those by the speaker via contact information that you provided at the time of the registration. Again, this webcast can be viewed on demand. Lab Roots will alert you via email when it's available for replay. We encourage you to share with any colleagues who may have missed today's live event. And again, thank you, Dr. Prince. Until next time, goodbye, everyone.
Thank you.